Welcome, everyone. Thanks for joining us, even though some of you may be busy with pre-holiday crazy season or joyous season. But thanks for taking some time with us today to talk about long COVID. My name is Susan Law. I'm the Knowledge Mobilization Lead for Long COVID Web and an Associate Professor at the University of Toronto. We have two wonderful guests today, both from the US. I hope no one accuses us of some recruitment strategies here, but we'll just get going in a sec here. So I'm going to start with a land acknowledgement. We wish to acknowledge this land on which the Long COVID Web operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Quick reminder of the purpose of these webinars. It's firstly to share evidence-based information, research results relevant for decision makers, researchers, clinicians, patients and families, and the general public. Secondly, to provide ongoing updates, spotlights on emerging evidence and scientific information about the activities of our national network and beyond. And thirdly, to contribute to reducing and managing misinformation about long COVID. Long COVID Web does have a code of conduct. You can see it on our website, but it's also in the link here, which essentially boils down to the fact that we value highly engagement around the science and its interpretation as well as its application. A commitment to reasoned discourse, as stated in our code of conduct, comes with a responsibility for all of us to ensure that any comments or questions remain within the spirit of a positive, constructive, and respectful discussion. So we welcome any and all questions and comments in this spirit. Thank you. So your cameras and mics are off, but please post your questions in the chat. We will pause for Q&A after each speaker, and we'll do our best to review and address as many questions as possible. These sessions are recorded, and with permission from the speakers, we will be posting the session afterwards to share it online following the session. And we do welcome your thoughts about how these sessions could be most helpful. So please, we have a very short feedback survey, which I'll ask my colleague to post about 2/3 of the way through the webinar, and any comments, suggestions, welcome there. This is the feedback survey. I'll just say thank you. And we will turn it over to our speakers. We're going to start with Dr. David Putrino, who's going to talk to us about long COVID and vagus nerve stimulation, results from a placebo-controlled, randomized controlled trial. He joins us as the Nash Family Director, Cohen Center for Recovery from Complex Chronic Illness at the Icahn School of Medicine at Mount Sinai in the US. So thank you very much, Dr. Putrino, for joining us, and I'll turn it over to you.
No worries. Thank you for having me. I'll try and burn through these slides as quickly as I can so that we can have questions. And I'm just going to get all of these meeting controls out the way. Okay. So yeah, I am speaking today about a clinical trial that we ran looking at vagus nerve stimulation for people living with long COVID. It was a placebo-controlled randomized controlled trial, meaning that people were randomly assigned to either a placebo intervention or an active stimulation intervention. First and foremost, just sort of starting with why we wanted to look into vagus nerve stimulation. Our data, as well as publications that have been put out there by many others, have shown us that around at least 70% of people with long COVID also experience autonomic nervous system dysfunction. This is dysfunction of the part of your nervous system that controls things like blood pressure, heart rate, body temperature, digestion, etc. Many people with long COVID experience dysautonomia, sometimes also referred to as POTS, postural orthostatic tachycardia syndrome. And it can drive significant disability. So as one of the biggest drivers of severe symptoms and disability, we wanted to see if there were any safe non-drug ways of intervening on autonomic nervous system dysfunction. And of course, quite quickly, one of the things that was on our radar was vagus nerve stimulation. The vagus nerve regulates the majority of our autonomic nervous system activity. It's this incredibly long nerve that has so many pathways. You can sort of see it mapped out here, that runs all the way through the body, innervates all of our organs, and really does a lot to control all of these things that are typically under autonomous control. And if we can use the vagus nerve stimulator to regulate vagus nerve function, there's a real chance that we may be able to address some of the autonomic nervous system dysfunction that we're seeing in a way that doesn't involve drugs, as we know that many folks with long COVID and other infection-associated chronic conditions and illnesses experience medication sensitivities. And maybe we have less side effects and more effective therapies. So that's the dream. The device that we utilized in this trial was a device called the NeuroSim. So this is a device that stimulates the vagus nerve via a part of our ear called the tragus, which is, if you can see me on the camera, this part of the ear here that sort of sits here. And in a majority of individuals, what we know is that there are enough fibers of the vagus nerve running through the tragus that you can successfully stimulate the vagus nerve using this technology. It was a sham-controlled trial, so people were randomly assigned one-to-one to either a sham stimulation condition or an active stimulation condition. And at the end of the trial, crossover was available. So people who were randomized to the sham condition were given the opportunity that they could cross over into the active stimulation protocol. Of course, they were not told that it was an active stimulation protocol. The blind was still maintained, but crossover was available. The parameters for stimulation were people were asked to perform 45 minutes per day of stimulation of the vagus nerve, and the same for sham. So people were still asked to perform 45 minutes a day. In the sham stimulation protocol, we had certain settings built such that the patients could feel the stimulation quite strongly, but it was not at a frequency or an intensity that actually caused effective vagus nerve stimulation according to the manufacturers of the device and the available literature that we have. In terms of what we were measuring, our primary outcome measure was the Compass 31. This is a outcome measure that is used, a sort of pen and paper outcome measure that is used, that is well validated in autonomic nervous system dysfunction, that allows us to better understand what someone's autonomic symptoms are like on a regular basis. We also had secondary outcome measures that were pen and paper. We looked at the fatigue severity score, the neurological quality of life, and the DePaul symptom questionnaire, the PEM version of that. And then we also had some exploratory outcomes. Namely, we were very interested in trying to understand, we captured saliva so that we could track proteomics that were going on along the stimulation protocol. For those of you who don't know what proteomics are, it's basically allowing us to measure whether or not our intervention is causing certain proteins to be expressed, which then go on to drive different physiological features or physiological behaviors. So we captured saliva for proteomic analysis. We captured blood and plasma to do inflammatory cytokine analysis. And we also captured capnography because we have published in the past that many people with long COVID experience low levels of carbon dioxide. And we wanted to see if vagus nerve stimulation could improve that. So let's start off with the basic results. And I won't beat around the bush here. We captured, we were able to get 40 people who completed the protocol. 20 were in the active group, 20 were in the placebo group. They were well matched in terms of gender and age. We recruited more women than men in the trial. Median age was in each group was sort of sitting around the 40 years old range. 10 people chose to cross over from placebo. So all said and done, we had uh, 30 people who completed a full active protocol, 20 people who completed the placebo. We failed to reach a significant between group difference in the primary outcome measures. So although some people in the active group did experience improvements per the Compass 31, we also saw improvements in the placebo group. We also just did not see a substantive difference between the two groups when we went head to head in the Compass 31. This was also the case in our secondary outcome measures related to fatigue, post-exertional malaise, and quality of life. Although some people improved, not everyone improved. Now, if you've heard me speak about long COVID before, you probably are aware of the fact that even though we are out there running clinical trials on anything and everything for long COVID, we really believe that there is no single silver bullet, one intervention for every single long COVID patient. Instead, what we try to do is we try to understand via responder analysis who responded and why they responded. And so in this case, like I said, we didn't have a significant improvement in the active treatment group over the sham control group, but in the active treatment group, we did have some people who made really significant gains. And so we wanted to try and understand what was special about those folks who made really significant gains. As it turns out, when we did our responder analysis, we started to see really strong correlations between IL-10 levels. So this is this plot down here. IL-10, which is an inflammatory cytokine that is actually related to reductions in neuroinflammation. So as you see IL-10 increase, you can imagine what you can assume from that is that that people are becoming less and less prone to neuroinflammation. So as IL-10 increases, typically you start to see less and less neuroinflammation. And what we saw is that in the active group only, and not in the sham group, the higher people's IL-10 levels climbed after the protocol. So the higher their per visit over time, the higher their IL-10 levels got, the more gains that they made in the Compass 31, which was encouraging to see. And similarly, also in the active group, not in the sham group, as people's CO2 levels increased over time, we also saw improvements in their Compass scores. So we started to see in our responder analysis these very interesting patterns around physiology and who responded. And so we wanted to take that a step further because, we're understanding that we didn't hit our primary outcome measure, but we also want to listen to our patients. And our patients often tell us that vagus nerve stimulation helps. So now we did some proteomic analysis, and I will really want to credit Marcelo Freire from the J. Craig Venter Institute, who did this incredible work. Now, this is just a volcano plot showing a bunch of, random names of proteins. It's not going to mean all that much to people unless you're absolute jets on salivary proteomics, which I am not. But really what I want to show is that active participants showed upregulation, this here in the red, of proteins associated with neural repair and regulation of the nervous system. And they showed significant downregulation of proteins that are associated with neuroinflammation in comparison to sham. So what this tells us is, yes, the active stimulation protocol is doing something, and it's kind of doing what it's supposed to do. It's helping the nervous system regulate itself. It's reducing neuroinflammation. But the problem is we didn't quite get to an effective outcome. So the key takeaways from this are that overall, the trial, as it was designed, failed. I don't want to sort of dance around this. We didn't hit the outcome measure that we wanted. That's okay. We've got lots of other trials going on. We have lots of exciting technologies on the horizon. As it stood at this dosage with this device, the trial didn't make a primary endpoint. Oops. However, there were many patients that report, that VNS is game changing for them. So when we dug deeper, we started to see physiologic changes that point to the idea that the vagus nerve stimulation maybe was pushing things in the right physiologic direction. We just weren't doing enough. We weren't doing enough of the vagus nerve stimulation. So the question that we have based on, on these key takeaways is, did we underdose this trial? Is 45 minutes once per day just not enough to drive the changes that we need to make a big difference in someone's symptoms and someone's life? And also, is there anything else we could be doing to really be boosting outcomes as we think about maybe we could do another clinical trial? And I think in both cases, the answer is yes. And so here's what we're planning moving forward as it pertains to vagus nerve stimulation. I was reading a paper by Kevin Tracy. If you are not familiar with Dr. Tracy's work, he's one of the biggest vagus nerve gurus around. He's done some of the most seminal work, not only on vagus nerve stimulation, but just vagus nerve anatomy. And he published a paper in 2022 showing us that famotidine, which is Pepcid, which is a antihistamine that many people with long COVID take to good effect, actually activates anti-inflammatory pathways in the vagus nerve. So he published this paper in animal models, but it was really, really interesting. It's also really interesting because we know that there have been placebo-controlled, randomized controlled trials using famotidine that show us that famotidine can improve cognition, can reduce overall symptomatology in people with long COVID. So it appears to be, but everyone was a little bit sort of cagey on the mechanism of action of that. Some people said, oh, well, it's MCAS. Other people said maybe it's reducing inflammation overall. And Kevin's group showed that famotidine is actually a stimulator of vagus nerve stimulation, of the vagus nerve, specifically of anti-inflammatory pathways of the vagus nerve. So this was something that caught my eye, and it made me think, what if we combine the two? Again, if you've heard me talk before, you'll hear me advocating strongly, not just for single therapies and monotherapeutics, although it's important to run monotherapeutic trials to establish safety feasibility so you can move on to combination trials. I firmly believe that the answer in finding good interventions for people with long COVID lies in combination trials and combination therapies. So to this end, what we hope to do next, or if anyone else can do it and has the funding to do it, please steal my idea and do it. But what we hope to do is TAVNS at a much higher intensity. So rather than 45 minutes once a day, let's do 45 minutes 3 times a day. Let's really give vagus nerve a shot to work on regulating nervous system activity. And what we want to do is combine that with what has previously been published as an effective dose of famotidine in people with long COVID, namely 40 milligrams twice per day. So this will be the next trial involving vagus nerve stimulation that we're going to be trying to get off the ground. And of course, we're always happy to chat with others who may have funding or may have a way of getting it done faster than us. But this is where we stand currently on vagus nerve stimulation in long COVID. Like I said, I want to give some time for questions. So all I want to do is acknowledge the wonderful people who did this work and funded this work. And I'll leave it there for questions. Thank you.
Terrific. Thank you very much, Dr. Putrino. There's a bunch of questions, so I'll try to speed through them here as well. So the first one is, did the people who improved in both groups have COVID for less than a year?
In general, people who were included in this trial, the median amount of time that they had been symptomatic with long COVID was 14 months.
Right. Okay. I think you might have answered part of this, but was the increase in IL-10 associated with time using the NeuroSim?
It was, yes. So the actual measurement was how much had IL-10 increased from visit 1 through to visit 5.
Perfect. Thirdly, how was the neurosim intensity determined? Did patients follow the manufacturer's instructions for choosing the level, i.e., increasing slowly, or was the intensity predetermined?
The intensity was per the user manual, which is basically building up to the limit of tolerance.
And a comment that the trial of 40 people seems underpowered in the first place.
Um, that's an incorrect comment. So I appreciate the comment. Of course, in a perfect world, I would have hundreds of people. It was appropriately powered to show 20% change in the Compass 31, which is associated with the minimal clinically important difference and minimal detectable change of the Compass 31. So let's be careful about throwing around assertions of underpowering when, we know how to do clinical trials. We appreciate it. We can always say at the end, more people would be great. But I really want to be protective of my team, who are amazing.
Great, thanks. Question about can using a cheap TENS machine with an ear clip recreate this study?
Potentially. There are a number of people doing all sorts of wacky and wonderful things to stimulate the vagus nerve. Again, I would actually point to Kevin Tracy. He has some methodology where he does utilize a cheap TENS machine with a particular stimulating wand, and he kind of hits not the tragus, but actually two different parts of the ear. And he believes that that is more reliably stimulating the vagus nerve and at a much lower cost than the units that are available.
Thank you. Many clinicians treat POTS as one generic diagnosis, but a big chunk of physiology points also to low preload/venous pooling mechanism with reduced venous return. Cardiovenous syndrome, a form of POTS that is now showing up in many youth, teens, children, etc. The symptoms overlap a lot. We tend to mistake it with regular POTS. Root cause is the blood not moving. Thoughts on that?
Yeah, I mean, I think David Systrom is the authority on this in terms of the work that he has been publishing with invasive CPET. I totally agree. Now, when we want to talk about where we were underpowered to do subgroup analysis in great detail. But we were seeing trends toward people with orthostatic intolerance symptoms on the Compass 31 being more likely to respond to the vagus nerve stimulation. However, characterizing orthostatic intolerance is also a mixed bag, and there's a lot of work to be done. So, going deeper is always going to be needed in these groups. But I totally agree. If you've seen one person with POTS, you've seen one person with POTS, and you've got to capture many thousands. Yeah.
Thank you. Is there a chance that there's something that will push the positive changes you saw that is not vagus nerve stimulation, such as meds? Also, were the numbers of people that the vagus nerve stimulation helped significant?
So I do believe, clinically we use medications in our center. So, we use ivabradine, we use mestinone. We're watching Systrom's work on LDN plus mestinone. We use midodrine. We use IVIG. And what we are really trying to do, a big goal of our center, is right now it's kind of trial and error, and it's talking to the patient about what they may be able to tolerate in terms of medications or in terms of other interventions, non-medication interventions, and then just kind of like in these 4 to 6 week blocks, or up to 3 month blocks, kind of figuring out, okay, well, let's try this intervention, let's try that intervention. Again, I don't believe in silver bullets with this illness. I believe in characterizing physiology and matching interventions to physiology. And so that's where we're trying to get to with the work that we're doing. In this case, we had 15 people in the active treatment group who met our threshold for a responder, which is a 30% change in the Compass 31.
Great, thank you. Would an implantable VNS, like used for seizure disorders, be considered? Will that perhaps be much more effective, especially for the responder group?
It is something that we are discussing. I think it's a discussion we've had both with the FDA and with some potential funders. Not just an implantable VNS for stimulation, but implantable VNS for recording is something that we're looking at. And I especially think that this might be something that may be worthwhile trialing in our very severe cohorts. Folks where nothing else is working and they don't have any other options. This could be a really interesting starting point for people who have, fewer options and really no open clinical trials for them.
Thank you. I read that the vagus nerve can be overstimulated and that perhaps less is more, such as 15 minutes might be better than 45. Is there any dose response evidence from other populations? Does this depend on the baseline status of patients?
So it's a great question. Again, I'm going to point people to Kevin Tracy, who does some really interesting dose response work. Now, we're stimulating afferent fibers of the vagus nerve through the ear. So these are fibers that, when stimulated, promote parasympathetic nervous system activity, where in the majority of long COVID patients the vast majority, the overwhelming majority of long COVID patients we've seen, the problem is too much sympathetic nervous system activity and not nearly enough parasympathetic nervous system activity. We stayed within parameter for an effective dose response in this trial for safety and feasibility reasons. But what we saw in the proteomics and what we saw in the blood biomarkers really points us toward the fact that we just didn't stimulate enough or long enough. So although, I would say I can't say anything with certainty, that which can happen will in the nervous system, and it's possible that maybe we were overdosing. The physiological data we captured alongside our symptom data indicates that we underdosed, not overdosed.
Great, thank you. I'll take one more question and then we'll switch over to our second speaker. Thanks, but there are a number of unanswered questions, and I wonder if you might be able to have a look at the chat while Dr. Nath is presenting and provide a few answers there if that's possible.
That's good.
Thanks.
Yeah.
So the next question is from Dr. Nath. I wonder if stimulation of the parasympathetic system might lead to vasodilation and hence aggravation of POTS in some.
I would imagine that it's possible. I mean, we have certainly had folks who have had we've certainly had folks who have had issues with vagus nerve stimulation, speaking anecdotally. In the trial, we did not have any adverse events related to the stimulation. Again, it's possible, but we didn't see it in the trial.
So back to the questions. Do you think that the neurostim may help people that have gastrointestinal dysautonomia?
I do think, again, I think it is possible. However, I will say that in terms of the results from the study, in the gastrointestinal symptoms subscore of the Compass 31, we didn't see a whole lot of movement in the outcomes there. So it was one of the things that was less affected by the vagus nerve stim.
Thanks. Was the definition of dysautonomia limited to OI, or did it include symptoms like sweats, chills, pain in vagus distribution, etc., i.e. dysautonomia that is not POTS?
Yeah. Yes, individuals really just had to have a physician's diagnosis of dysautonomia, and then we went in and performed additional assessments to understand what sort of flavor of dysautonomia symptoms they were experiencing. The Compass 31 is of course very good at sort of aggregating that out because it asks 31 questions about varying different symptoms and then gives you an overall symptom score. But we did not sort of limit it to a specific sort of dysautonomia. We allowed everybody in. And now that we've seen some of the responses of the vagus nerve stimulation in subsequent trials, we may be a little bit more strict with inclusion criteria now that we're starting to generate an understanding of who gets helped and who doesn't.
I'm just going to jump to another question that I think is related. You may have just answered the question, but do you think this is more effective for certain types of dysautonomia, like when it's caused by the vagus nerve versus immune-mediated small fiber neuropathy?
Absolutely. Yeah, I think that's a great observation. I mean, right even back to the GI symptoms, I think that when you see GI symptoms like gastroparesis, I think about all of the studies that have been published showing sort of a loss of nervous system function in the GI tract that can be causing gastroparesis, which is more linked to immune-mediated small fiber neuropathy, where you may respond to VYVGA, IVIG, or even things like rituximab. And that's not me making medical suggestions. That's just me listing literature that has been published versus in other cases where you have vagus nerve dysfunction for whatever reason, chronic inflammation, direct infection of the vagus nerve, etc. These things might be helped by vagus nerve stim.
Okay, thanks. Were there any common characteristics of the responders?
In terms of symptoms, as I mentioned earlier, the orthostatic intolerance symptoms tended to be alleviated more than non-orthostatic intolerance symptoms. Other than that, we didn't see anything jumping out at us. And like I said, that was something that we weren't powered to say with any level of statistical authority. It was just something trending that we took note of.
Thanks. With the famotidine, do you have any concerns in regards to long-term or high-dose use and possible side effects? And as always, thank you for all that you do.
Look, I do think it's a concern. Long-term use of antihistamines is something that bothers me a lot in the sort of community. I mean, I know that we have mast cell activation issues going on in folks with long COVID, and use of H1, H2, even H3 blockers, it can be game changing. But yes, as we study the long-term use of anticholinergics and the studies that have emerged, it would be good if we can find more effective treatments to get people off of long-term use of these drugs.
Thanks. Was the level of tolerance per study participant recorded? If it is different per participant, could those that had lesser positive results potentially be using a lower setting? And thanks again for all the research that you're doing.
So we did not have any adverse events that caused us to stop the trial or stop participation in the trial in this particular trial. So tolerance wasn't an issue that we faced. I would imagine that we could certainly try, some dose responses in folks who can't tolerate higher levels of stimulation. But again, it's not something that you're sort of saying, turn this thing up to like a really difficult level. Tolerance of the stimulation really is the dosing level that you're going for. So we're specifically instructing people not to push into painful or uncomfortable levels of stimulation. You want the stimulation to be comfortable. And so for whatever that is worth, we did not have any tolerance issues.
Okay, terrific. Thanks. Sorry, I missed that note that the slides are ready, so we're ready to go, Dr. Nath. And thanks again, Dr. Putrino, for the extended Q&A session. And back
No
to you,
worries.
Dr. Nath. Thank you.
Nice. David's done a fabulous job. You can see he has a large fan club here. It's going to be a hard act to follow. But I like to tout my own Canadian roots. So I was just telling Susan earlier, I was born in Saskatoon and grew up there early part of my life. And then I was a faculty member at University of Manitoba for 7 years, from 1990 to 1997. And I have a lot of family in the Toronto area. So uh, familiar with the winters. Actually, in some ways, miss it to some degree. I'm not. As you get older, the winters get harder to face.
We'll try to send you some of that one day.
Very fond memories of my youth there. Okay, so I'm going to talk a little bit about the neurological complications of long COVID and the therapeutic approaches, and also tell you a little bit about the clinical studies that we are doing over here on long COVID, trying to develop new modes of immune modulatory therapies. And we come from the perspective of been studying infections since the 80s, the beginning of the AIDS pandemic, and with every pandemic, I think most people originally don't believe that infections haven't caused anything in the brain, and we've proven them wrong every time. But what we've learned is that you really have to show pathology to people to really convince them. So right in the beginning of the pandemic, I spent a lot of effort at trying to obtain autopsy material. That wasn't an easy task to do because most people weren't really doing it. But we conclusively showed that there are pathological changes that are unique to this disease. And I'll share some of those observations with you. Okay. Oh, yeah, so you control my slides. Yeah, so that's one good thing about working with the federal government is you have no disclosures, no conflicts at all. Okay, so first thing is that this is not unique. We think that, okay, the long COVID is a new disease that we've just heard about. That's not the case. In fact, these post-infection syndromes are very common with lots of different infections, okay? And they just get their own unique name. But when you look at it, they have a lot of overlap in symptoms, right? So each one has been associated with an infection. And then you have this whole category of MECFS, where most often we don't know what the infection is because it's really remote, but the symptoms overlap. So I think this is also a post-infection syndrome. And what we are really fascinated about is that why do infections really lead to this? And our hypothesis really is that you have persistent viral remnants that really drive the immune system, causing these symptoms. And so that's been a focus of our lab for a long period of time. And we study a variety of different infections to address these hypotheses. Um, so the so the next thing is that people have tried to define what long COVID is, and there are all kinds of terms that have been used to describe it, and lots of different definitions. So as soon as you get into the realm of multiple terms and multiple definitions, what it really means is that nobody knows what it actually is. And so here's the attempt of the WHO, right? And they say the continuation of development of new symptoms 3 months after infection, and that it should persist for over 2 months without any other explanation. So it's still, it helps with some kind of definition, but it's still pretty vague. The way I look at it is that I broadly divide them into two categories. Okay, so you have individuals who first became really ill, and then what happened is that they get out of the hospital and they have persistent symptoms. So that's not surprising. I mean, if you're ill with anything that requires hospitalization, it's going to take you a while to get better, or you may never get better completely. But that's because in that acute phase, you've damaged various kinds of organ systems, and so their symptoms are going to persist. But that's all related to that acute injury that occurred. Okay. Now you have a second set of individuals. Here, what happens is the symptoms, the acute symptoms, were not that severe. You may not even get hospitalized. You may actually stay at home. You may not even go to a doctor. Okay. And then what happens is that after some period of time, you start developing new symptoms. But you relate that to that infection you had before. The pathophysiology of this has to be very different than the first one. Unfortunately, they all get lumped together under the same umbrella of post-infection syndromes. And this second category of individuals, I think, are the important ones to study. And really, those are the ones we should define as long COVID in my mind. Okay, next slide. Okay, now another question that comes up is that what strains of the virus can cause long COVID? And we say, well, maybe the early ones were the ones more important, and maybe the later ones are not. That's not the case. It turns out that even the ones that exist today are causing new cases of long COVID. So this virus, the pandemic is still ongoing. We behave as though there's no pandemic any longer. That's not really the case. Okay. And those poor folks who get affected by it and are developing new symptoms, just ask them. You know? So I think we got to be quite cautious in how we deal with this pandemic. Next slide, please. Okay, so as you know, David had pointed out, you have a category of individuals who have autonomic symptoms. And as we know, that if you talk to patients, they'll tell you they have a variety of symptoms. And so we try to divide them into 4 different buckets. There's a paper that just got published in Nature Communication. They divide them into 8 different categories. But nonetheless, I think here for our purposes today, I'm going to talk about these 4 categories, and you can subdivide them into more categories if you want. We have one broad category of exercise intolerance, and these patients present with this post-exertional malaise type of picture, like you see in patients with ME/CFS. Right? You exercise them, and then after some period of time, maybe the next day or whatever, they get so exhausted they can't do anything else. In fact, a cardiologist I saw from New York who got affected by COVID, and then she said that she couldn't even take a flight of stairs, and she would get so exhausted she had to lie down. She couldn't even do telemedicine any longer. You know? So it can be actually very, very disabling. And she was a cardiologist. She had her heart and everything checked out and can't find anything. You know? Cognition. So brain fog is a common play. And sometimes people don't even realize that they had brain fog till they go back to work. And once they're challenged, then they realize, you know what, I can't multitask any longer. And then there are a variety of pain syndromes that can occur. There are mood disorders that can occur. Patients can develop depression most commonly, but anxiety and psychosis has also been described. It can be new onset depression. A person here, a colleague of ours here at NIH, had no history of any psychiatric symptoms, and in his 50s, had COVID, became so depressed, he was afraid he was going to kill himself. So he himself went to the emergency room, gets admitted. He's doing fine now. So he was treated in the hospital, and now he's doing okay. So, and then a variety of pain syndromes can occur. You know? So a headache, I think, is a little bit different than all the other pain syndromes because the underlying etiology and pathophysiology can be different. So you can separate it out. All right, next slide, please. So what causes these things? And David pointed out very nicely that, you know, you have this inflammation that can do it. But I think they're all interrelated in a way. So you can get viral reactivation. There are resident viruses within our body, all kinds of things that we get infected with, and they don't always, leave our body. Epstein-Barr virus being one of them. We think that it's possible that some remnants of the SARS-CoV-2 itself may still be there. There's plenty of evidence to show that. And then there's immune dysregulation. So you can get B cell abnormalities that produce autoantibodies. You can get T cells that can be exhausted, and you can get macrophage activation. All these things can occur And so one can look at each of these arms and see how they relate to the pathophysiology of the disease. And I think that's important because you can develop interventions to block each one of them. Okay. So identifying individuals in whom um, either of these abnormalities exist will allow you to develop personalized medicine to block that arm of the pathophysiology instead of just randomly treating everybody with one thing. And I think David alluded to that as well. That you, from his study, that you need to identify the responders, try to understand what that is all about, and then treat them accordingly. And I think that's our attempt as well here, looking at pathophysiology. Next slide, please. So this is a paper published from the Yale group, and they showed that very nicely that in some patients you can get activation of Epstein-Barr virus, and maybe that too could be driving some of their symptoms. Okay, next slide, please. Yeah, you can advance the slides. Okay. Okay, so okay, so yeah, that's good when somebody else controls it. They can flip through a few slides and get me moving faster, right? Okay, so okay, all right, okay, we can stay here. So the virus infects the nasal mucosa, right? And so that's why you lose your sense of smell. And what I wanted to show you is that here's your nasal mucosa, and on your right upper side, and you can see there's a thin piece of bone, and then there's the brain over here. So originally we naively thought that the virus is in the nose, it can easily enter the brain. Turns out that's not really the case. In fact, what you find is you find a lot of virus in the nasal mucosa. You never find it sitting in the brain, or very, very rarely in the brain. So this is protecting you really well. So the question is then, how is it really causing all these symptoms? Yeah, next slide. Um, so people have tried to look for the virus in the brain, and they find that you can find some small amounts of virus, but very rarely, and in individuals, and in very, very small quantities. And as time goes on, the amount of virus is very, very small. Okay. So you still have to explain all these kind of symptoms if you don't find much of the RNA. We found proteins in the brain of acutely infected individuals. We had an interesting situation where we were able to do a brain biopsy of an individual. And we looked there, we found the nucleocapsid protein there. So people spend a lot of time looking for spike protein, but actually what we found is you find more nucleocapsid than you do spike. Okay. So that to us was actually quite interesting. All right. Okay. Next slide. And this is a group from the National Institute of Aging. And what they found was that if you look at the tongue papilla and do a biopsy, you can actually find these SARS-CoV-2 proteins there several months after infection. So the taste can be affected there, and the virus can reside in the tongue papilla. Again, it's not replicating virus because they're not infecting anybody, but you have bits and pieces of it that can still produce protein. Okay, next slide. And the group from San Francisco showed that if you look at the rectal mucosa, again, you can find RNA and protein sitting there. Again, their fecal material is not infectious, but they still have remnants of protein and RNA that you can find. Next question. And then there's a group from Boston that found that you can find protein circulating in the blood too of individuals many months after that. And that's been reproduced by a number of different groups. Yeah, next slide. Okay, so I showed you that yes, you can get reactivation of Epstein-Barr virus. You can have presence or remnants of the virus can be present in multiple places within the body. Then what happens to the immune system? Okay, let's go to the next slide. Okay, so you can get immune dysregulation that can affect the B cells, the T cells, and the macrophages. Yeah, next slide. Here, what we found was that you find that there's the B cells are abnormal in some individuals, whereby they don't switch. The B cell switching has to take place. You got to go from IgM to IgG. And what we and others have shown is that there's a clear block between the switching from IgM to IgG. So their B cells are not maturing. And if you don't mature your B cells, they're not effective enough to be able to counter the infection itself. And we found that in long COVID, and we found the exact same thing in ME/CFS2. So here's an immunological overlap between the two. The second thing on the bottom series of graphs there, what they show is they're looking at the T cells. And we look at these markers on the T cells that suggest that the T cells are exhausted. Okay. So the B cells are not maturing and the T cells are getting exhausted. So the combination of the two is pretty bad. That means you're not going to be able to get rid of the viral infection completely. And that's why these remnants of the virus are still hanging around in these individuals, I think. Okay, go to the next slide, please. And then what about the macrophages? If you have these remnants of viruses hanging around, what they're going to do is stimulate the innate immune system. Okay. And when you stimulate the innate immune system, you're going to see activation of macrophages and microglia. Here by PET scanning and by an autopsy tissue, the autopsy material was done in our lab, and the PET scanning here that I've shown is a group from the Netherlands. And they find that there's a lot of microglial activation in the brain of these individuals. Actually, we were quite surprised at the degree of microglial activation. For the small amount of virus that's present in the brain, microglial activation was surely out of proportion. The next slide, please. And we looked at the pons, which is the brainstem, and we looked at the olfactory bulb. And this brown staining is a protein called fibrinogen that's usually present in the blood, but it shouldn't get into the brain. We found there was a lot of this leakage of the blood vessels into the brain and the olfactory bulb. So there's something wrong with the blood vessels here that's causing them to leak. Okay, the next slide. And when we looked at the blood vessels more closely, what we found is that you find all these activated macrophages around the blood vessels, and you find very few T cells. If there was a lot of virus in the brain, you'd find a lot of T cells. There are very, very few T cells. Okay. But we found a lot of platelets that were sitting there, aggregating in the blood vessels. So you find these microclots. You find also damage to the blood vessels themselves, which makes it leaky into the brain. Okay, next slide. But there are a lot of, so this photomicrograph on top shows you how many blood vessels there are in the brain. So if you leak the blood vessels, you got the rest of the brain parenchyma is very close to blood vessels. So you cause havoc within the brain if you damage blood vessels within the brain. And the bottom is a patient that I recently saw. Shows a lot of atrophy within the brain, and you get these white punctate lesions showing that there are blood vessel abnormalities in a patient with long COVID. And she's complaining of sleep disruption, memory impairment, inability to return to work. Pretty classical symptoms of long COVID. All right, next slide. And we found that when we look for the neurons in the brainstem, that's where you see that a lot of the pathology for neurons is in the brainstem, which is very interesting. Because as David was talking about the vagus nerve nucleus is in the brainstem. And a lot of the pathology that we find is around the vagus nerve nucleus itself, suggesting to me that it's quite possible some of the virus is not coming through the nose, but rather coming along the respiratory tract, because that is innervated by the vagus nerve and maybe retrograde transport up into the brainstem. And that's leading to neuronal loss and microglial activation in the brainstem itself. Okay. All right, next slide. Okay, so what is the consequence of all this inflammation in the brain? The problem is that a lot of neurodegenerative diseases are protein aggregation diseases, Alzheimer's, Parkinson's, ALS. You have different types of proteins that aggregate in the brain and they lead to these diseases. If you have inflammation, you accelerate the process of aggregation. So a challenge here is patient presents with, difficulty, elderly patient with difficulty thinking. They say, well, I got COVID and now I have all these problems. The thing what you have to think about is it really long COVID, or is it that this inflammation from the long COVID accelerated the process of Alzheimer's? Okay. And that, I think, is very important to differentiate between the two. So one has to be cognizant of the fact that you could be accelerating neurodegenerative diseases, And now when people have started looking at these cohorts, that seems to be the case. And very nice studies coming out of NYU showing that to be the case here. Okay, next slide. So now, because there's no good biomarker for long COVID, and long COVID still is a clinical diagnosis, and we know our clinical acumen is never that good. Okay, there are a lot of misdiagnoses that occur. Comorbidities occur in the population too, so that makes it challenging to really design clinical trials. Right? There's no accepted biomarker. Symptoms are subjective. Case definitions are vague. Big pharma has no interest, right? And there's a lot of public pressure to actually do clinical trials. You take all of this together, you have a real challenge on your hands. So what do you do? I mean, we understand the pathology, we understand all these things, and you say, well, how do I do clinical trials probably in this patient population? Yeah, next slide. Okay, so there are placebo-controlled studies. A lot of them, several of them have been done. Most of them have failed. They don't really work for all the reasons that I described before. So that makes it even more challenging, right? Next slide. But what has been shown is that if you were to treat patients acutely with antivirals, you can actually prevent long COVID from taking place. So that seems to hold up in multiple studies. Okay, so treatment of acute COVID is really important. Next slide. And the other interesting thing is that if you were to uh, look at these vaccination studies, the more vaccinations people get, the less the chances of developing long COVID. Okay, so these two things are things that one can do to prevent long COVID. But you say, well, I've already now got long COVID. What do I do now? Okay, next slide, please. So we are doing a few things at NIH. Number one is we're trying to develop this Hingston scale, which will be a objective scale for measuring all these symptoms of long COVID. I'm not going to go into the details of it, but the scale is still in development. Next one. And we have three things ongoing. Number one is to really look at the reservoirs in the body for long COVID patients, look at the viral reservoirs where they're present. So we are going to biopsy any tissue we possibly can and take every single body fluid we can actually take. And so that's ongoing at the moment. We're doing a clinical trial in IVIG and long COVID, again, with the same idea. What we want to do is identify individuals who are responders and try to understand why they get better. And lastly, we just got approval from the FDA to do a study with checkpoint inhibitors in long COVID patients, a pilot study of only 10 individuals, a safety study. But nonetheless, I'm very excited about that possibility, because if that works, we can actually reverse the entire process of long COVID. Next question. Next slide. We're going to skip this slide next and go to the acknowledgments. Skip it. Next slide. So in conclusion, what I like to say that even though long COVID lacks a clear definition or a biomarker, persistent antigen, immune exhaustion, activation, and vascular compromise are the hallmarks of the illness. And treatments targeted at these mechanisms can modify the course of the illness. Okay, so we still have a lot of hope that we can make a difference. Yeah, next question. Next slide. And there are a lot of people who really contributed to these studies, and I'd like to acknowledge all the neuropathologists, our MRI physicists, people in my lab, our clinical team, and the support that I have from our institute here. I'll stop. I'm sorry you've gone over because of the technical difficulties here.
That's okay. Thank you so much, Dr. Nath. That was terrific, and addressed lots of questions as you went along there too. Actually, I think some of which are in the chat. But I will turn to the chat now, and I did post that we will stay on for another 5 minutes.
Yeah. What we can also do is you can send me an email with your question, and I can always answer them via email too.
Terrific. Okay.
My email is simple. It's just first name avindra.nath@nih.gov. Okay. First name, second name at nih.gov.
nih.gov. Great. Perfect. Okay, thanks. So we will take a few questions now, though. First is many, but not all PCC patients have a combo of most symptoms. How to address that reality?
Yeah, so there are two things you have to do. Symptomatic treatment is still very important, you know, and so it can make a huge difference in patients' lives. So now it doesn't really matter what kinds of symptoms you have. If you're going to treat the symptoms, you treat them and you'll impact them. The problem will arise if you want to use disease modifying therapy, and therein we really don't have a good, it's all hit and miss, just like as David was describing. You try this and see what happens, try that and see what happens. And so, but I think once we have proper testing to try and understand the pathophysiology and make those things clinically available to people, then we could make real interventions. And so that doesn't deter me that they're overlapping symptoms. I think they're all manageable.
Okay, thank you. At the Long COVID Web Symposium that was held this past October, we learned that the post-exertional malaise is, at its root, complement activation. Do your findings support this? And secondly, there are meds to address complement activation. Are they going to be studied? If PEM is not an issue, the wasting could perhaps be addressed and help many others with their
I wish
baseline
these
symptoms.
things were that simplistic, right? Complement activation occurs in a lot of diseases that don't lead to PEM. Right? So there's got to be more to it than just that. But yes, if that's a major component, then obviously uh, there's an opportunity there to make a difference, and somebody should go ahead and try to convince the companies to pay for it. I think that's been the biggest problem, is to really get the funding to do it and put the resources together. But yes, I think it's a step in the right direction, but I think there's still a long way to go.
Thank you. Was the biopsy with the nucleocapsid protein in the brain from a living patient?
Where is the biopsy? What is the question? Sorry.
Was the
What?
biopsy with the nucleocapsid
Yeah.
protein in the
Yeah. What?
brain from a living patient?
Yeah, that was this was a patient who was going to undergo epilepsy surgery anyways, was admitted to NIH for epilepsy surgery. And this patient, as soon as they were admitted here, it turned out they got acute COVID. They said, well, we can't operate on this patient with COVID. So we left, the patient was treated for, at that time we didn't have any treatment. So we were just waiting for the patient to recover for 5 days. And then after that, we went in and did the surgery. So we took out the piece of the brain tissue. So that's fairly soon after that. And they developed acute COVID. So we took that opportunity to analyze it for the virus, and we found the nucleocapsid protein was still there. And the pathology showed that there was breakdown of the blood-brain barrier in the same way as we've seen before in other autopsy cases. So that's a published case, published in Neurology.
Okay, great. So which antivirals should we take to prevent long COVID?
Oh, Paxlovid, that's the one that is available in the United States, most commonly used. So you just, if you have renal impairment or something, then you have to adjust the dosage. But I think that's the one that's most commonly used. There's remdesivir and there are others too that are out there, but commonly we use Paxlovid.
Okay, thanks. So here we are. A big pharma does have a med that works on complement activation. It's considered an orphan drug for rare conditions. Long COVID is far from rare. So might the med developer be more than willing to conduct an RCT?
Yeah, convince the big pharma. My experiences has been very disappointing. So, I wanted to get the checkpoint inhibitors from big pharma, and I contacted Pfizer, I contacted MSD, MSK, and both of them have them. They told me no. Then I even went to the FNIH. I even talked to NIID. They approached these companies to say, okay, can you fund the study? And they said absolutely no. So the thing is, and I was talking to Steve Deeks, he says that big pharma, they've tried to get funding from big pharma. They're not interested, and the reason they're not interested is because the definition of the disease is not clear, the biomarkers are not clear, and so they don't want to invest in the disease if you don't have these concrete things to go by. And so, anyhow, if you have a way or somebody who can give you the drug, then I'm sure a lot of people will be willing to do the clinical trial. These things are very expensive to do. Nobody has the resources, you know. But if you can lay your hands on them and you can convince these companies, and it's very interesting. People will come to NIH and the government and say, "Well, you should do this, you should do that." Why don't you go to pharma and tell them you should do this and do that? You know, protest to those guys and have them shame them to do the clinical trials for us. I think we're willing to do it, but you're pushing the wrong people. Yeah, they are the big pockets. They are the billions of dollars that they're sitting on. You should push them to give their drug and do the clinical trials. I don't have anything. I mean, I got $2 in my pocket. What am I going to do for you?
Great point. How do you believe mast cell activation syndrome affects the brain?
Yeah, so that's not been studied very well. There is some mast cell stuff we've done in MECFS. We looked at it, at least in our population, which is a very select population. There, we weren't able to really find it. But there's fair bit of literature suggesting that it can. There are mast cells in the dura. The dura has it. So, and there's a fair bit of literature on mast cells and multiple sclerosis, older literature from some time ago. So theoretically, it's quite possible that mast cell activation can affect a brain, but demonstrating that has not been an easy task.
Great. Well, a question here. Do you think pharmacological companies would be more willing to do these studies if there were billable codes for insurance and diagnostics?
I don't think that's going to change it.
Oh, and there's a follow-up
Those
question.
are insurance companies, not pharmaceutical companies. Pharmaceutical companies don't care about billing codes,
Right. Good. There's a follow-up question about the the participant with the brain biopsy. So, are you saying that the nucleocapsid was found in the brain of a living person a few days after infection?
That's correct.
Okay. Great. Thanks. Oh, someone has suggested that you take to Twitter, as Dr. Putrino does. It reaches so many.
Oh, we're not allowed to do Twitter and the federal government. Totally banned from social media. So
Okay.
I would love to do it. I think it's a great mechanism of interacting with people, but we cannot have any social media presence.
Okay, thank you. Last question here. IVIG has been shown to work in post-viral neuropathy and dysautonomia, even decades later. It just depends how much permanent nerve damage has happened versus healable damage. And then a comment, SFN is driving a lot of the autonomic and GI issues too. Any thoughts on that?
Yeah, so I think that's very reasonable. You got to identify the right patient population to treat them. Not everybody responds to IVIG. It's a very expensive treatment. So I think what the key to all of these things is to have a potential, identify what who are the patients who are most likely to benefit from them, and then I think you have a better chance. I mean,
Okay, I think we'll close it here because it's almost 2:15, and I just want to say thank you again to both of our speakers and Dr. Nath for going through many of those questions. But if there are more questions, please do, as he suggested, email him directly for the answers. Thanks so much, everyone, for attending. Have a brilliant holiday. Be kind to yourself and others, and I hope you are able to celebrate something at some point over the next little while. So take care, and we'll see you back in January, and everything will be posted afterwards. And if you have a few minutes, please do provide some feedback. The link was shared again by Nick just in the chat there. So thanks, everyone. Take care.
thanks very much. All right.